Hello, everyone. Thank you for joining us today for this fifth webinar on integrative oncology organized by Oncia Community. My name is François Domecq, and I'm the co-founder of Oncia Community. Oncia Community is a cancer foundation dedicated to support cancer patients, people affected by cancer. So our mission is to raise awareness of integrative oncology and to accelerate the development of complementary cancer care centers worldwide. So today, this webinar is focusing on the key aspect of integrative oncology and complementary cancer care. What could you expect to learn? We will describe how these practices are transforming cancer care in improving patient outcomes and also patients' quality of life. We are very proud today to welcome Dr. Lorenzo Cohen and Dr. Gabriel Lopez. They are experts in integrative oncology. Dr. Cohen is the professor and director of the integrative medicine program, and Dr. Gabriel Lopez is the associate professor and medical director of the Integrative Medicine Center. They are both working in MD Anderson. So thank you very much to be with us today. So they will share with us their expertise and the latest work in integrative oncology and its implementation at MD Anderson. And the agenda will cover the importance of integrative oncology to improve cancer care. Also, the importance in managing side effects. They will discuss how this model is implemented at MD Anderson and also how you could implement this model in your practice. After that, we will have a live Q&A session where you could ask questions to Dr. Cohen and Dr. Lopez. So, but before we get started, I would like to share with you some practical details. So the webinar will last 1 hour. It's being recorded. A replay will be available on our website. So if you need to make comments or questions during the presentation or after, please use the Q&A buttons and not the chat button. So the chat button is disabled. So we will answer all your questions at the end of the presentation. So now I hand over the floor to Dr. Cohen, and thanks again to be with us today.
Thank you, François, and to your wonderful organization for inviting us, for putting on these webinars, which are extremely important to try and educate the larger medical community on practical things that we can do to help support our patients. We look forward to sharing today a more general overview of the field of integrative oncology. And in the future, we can go deeper into some of the specific topics, perhaps driven by the interest of this community attending today. Dr. Lopez and I will be a bit more tandem. I'm the overall director of the program, but not being a physician. I don't see patients. I don't directly work with patients. We work together to sort of set the vision and mission of the program. Primarily oversee the research component, and Dr. Lopez, being a medical oncologist and also board certified in palliative care, oversees the medical component of our formal integrative medicine center. So he will start us off with a focus on the clinical side, and then I'll come in the second part and talk about some of the research efforts that we are doing at MD Anderson, as well as what is happening in some sense more globally around the field of integrative oncology.
Thank you, Dr. Cohen. Thank you, Francois. So I'll start by sharing that when we think about integrative medicine, it can mean different things to each of us. It can mean different things to our patients. And sometimes in this confusion, there can be a lack of awareness about what recommendations, what is it that we read out there about integrative therapies that's true, what's not true, what's based on evidence, what's not based on evidence. And so a significant part of what we do in integrative oncology is making sure that any recommendations that we're making to our patients and their families and their caregivers is based on the best available evidence so that we can help support their cancer treatment and also help them have the best available treatment outcomes. So one important thing to understand as we begin today is also the difference in different terms that are sometimes used interchangeably. And I'd like to offer definitions to help us have that framework within which to think about the conversation that we're going to have today. So alternative medicine is something used in place of conventional medicine. Complementary medicine is used together with conventional medicine, and integrative medicine is used together with conventional medicine in a deliberate manner that is personalized, evidence-based, and safe. An example would be with acupuncture. If someone is thinking about using acupuncture to cure their cancer, that would be an alternative use of acupuncture. If someone says that they read about acupuncture, heard that it was very nice, and decide to do it alongside their cancer therapy, that would be a complementary use of acupuncture. If someone is experiencing, for example, chemotherapy-induced nausea, vomiting, and is recommended the use of acupuncture to help with relief of that cancer-related symptom, that would be an integrative medicine, evidence-based use of acupuncture to help that symptom. Now, when we think about integrative medicine in oncology care, we come to this term of integrative oncology. And so I'll go ahead and read to you the comprehensive definition for integrative oncology that was now published in 2017. And this really helps to bring together different areas that sometimes are not always thought about as being a part of integrative oncology or integrative medicine, because the focus is not just on herbals, it's not just on supplements, not just on integrative therapies, but it's about taking care of the whole patient. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications from different traditions alongside conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. In our own investigation about the use of integrative medicine approaches in the context of cancer care at MD Anderson, we had a survey that was completed between 1998 and 1999, where we asked patients about their use of integrative medicine during their cancer treatment. If you bring your attention to the area that's in the red box, in that second column, it says, CAM overall, excluding spiritual and psychotherapy, combined complementary and alternative medicine with conventional therapy. 75% of patients surveyed in outpatient centers at MD Anderson were using some kind of complementary and alternative medicine together with their conventional cancer therapy. If you move to that third column, you can see that only 60% of patients were discussing their use of complementary medicine with their physicians. If you go across this table, you can see that depending on the specific type of complementary and alternative medicine, there can be quite large differences in how often patients engaged in conversations with their physician about their use of complementary and alternative medicine. this kind of information really drove the awareness of the need to have conversations with patients about their use of complementary alternative medicine to make sure they were evidence-based and safe. So I'll now bring you to our Integrative Medicine Center. Dr. Cohen had mentioned earlier that we have an integrative medicine program. The Integrative Medicine Center is part of the Integrative Medicine program. The center is our area where we deliver clinical care for our patients. This includes physician consultations, as well as working with patients on receiving integrative therapies, for example, acupuncture and massage.
And not to give you the misimpression that, you may all know that everything we do in Texas is big. This building up on the top left is not all belonging to integrative medicine. We have
Half a floor.
Probably say half a floor, but we do have one of the best views of the medical center. And then you see here on the bottom left what it looks like as a patient walking into our center.
And so what does it take to bring together all of the different services and resources needed to support this kind of integrative medicine center to provide care for patients? Right now, our program includes, as part of the clinical care delivery, 5 physicians, 2 advanced practice providers, 2 health psychologists, 4 massage therapists, 5 acupuncturists, 1 dietitian, 1 physical therapist, 1 music therapist, and a yoga therapist, as well as an administrative group that helps to support our clinical efforts. Now, fundamental to what we do in our Integrative Oncology Clinical Center, and as far as how we work with patients in developing their integrative medicine care plan, is having patients first meet with one of our physicians for the Integrative Oncology physician consultation, where we ask patients about why is it that they're coming to the Integrative Medicine Center. I'll take a step back and mention that in order for patients to be seen in the Integrative Medicine Center, our model is such that the patient must first be an established patient at the MD Anderson Cancer Center and then be referred to us by one of the clinical teams within the hospital. We provide patients education on a variety of topics depending on what their symptom needs and what their interests are. We have interdisciplinary teams to discuss more complex patient cases. And critical to how integrative oncology works is that we are part of the greater oncology team. We're not functioning independently of the oncology team. And so maintaining that communication with the primary oncology team about what is being done, what is being recommended to the patient is critically important. I'll share with you the model that we use in helping to decide what that patient's integrative medicine care plan is. We follow the biopsychosocial model, and this was first proposed by George Engel in 1977, Journal of Science. He published about the biopsychosocial model. Our approach is looking at these 3 components of patient health and seeing how it is that through the support of areas of mind-body, physical health, and social health, integrating both members of our team as well as other clinical teams in the hospital. Here I've indicated the importance of collaborating with centers like psychiatry, spiritual care, the primary oncology team, physical medicine rehabilitation, supportive care, palliative care, cancer pain teams, social work. So again, we do not function independently, but we function collaboratively in helping to support this biopsychosocial model for our patients. So one important way that we help to how we work with patients in developing the integrative medicine care plan is through thorough symptom assessment. This is grounded in palliative care, a philosophy of the importance of really understanding not just about one symptom, but about the complex array of symptoms that patients might be experiencing that lead to the overall way that they feel. And so we developed a patient-reported outcome assessment that is now performed electronically that includes questions about, here, for example, the MICA, where we ask patients about what are the top 2 main areas of interest. This does not mean that is the only thing that we talk to patients about when they come to our center, but we want to prioritize those areas that are of greatest interest to them. And so when we use information like the MyCog and the top 2 areas that they're interested in, and also use other information, for example, we use the Edmonton Symptom Assessment Scale to ask about symptoms that they've experienced in the last 24 hours. We use that information together with this framework that is being shown currently, a model that links together diet, exercise, mood, stress, sleep, and symptoms as a visual tool to help patients understand how is it that integrative medicine can help support these different areas. How can we help support these different health areas that perhaps they haven't had addressed as in depth in the past, and recognize that these are things that are of high value and importance for their overall health, both during and after their cancer treatment. Here I provide an example of a patient. So, for example, if a patient is obese, we would discuss areas of diet, inactivity. We would discuss an appropriate plan of exercise. If they're experiencing an adjustment disorder, whether adjustment disorder with anxiety or depression, we would address those areas of mental health. Insomnia, also one of the key areas that we work with patients on. And then talk about, for example, if a patient is not sleeping well, that can affect their mood, that can affect their motivation to exercise or make good food choices. And poor sleep can also contribute to symptoms of fatigue beyond that fatigue they may already be experiencing in connection to their cancer treatment. So one important aspect of how our clinical model was built is that every interaction with the patient offers an opportunity for learning. And so in addition to clinical care delivery, we also have integrated within our center clinical research efforts. And so we have the Edmonton Symptom Assessment Scale delivered electronically to patients, both before and after each one of their encounters, as I've listed, massage, acupuncture, nutrition consultations, music therapy, yoga therapy. These assessments provide information that is used by the clinical providers at the time of their clinical evaluation and can be tracked clinically so that our providers can see what progress patients are having, both as a result of one session or after multiple sessions. And later on, we can actually use this data to use towards clinical research efforts. An example of the kind of clinical research that we've drawn from these pre-post Edmonton Symptom Assessment Scale findings in our center include this publication, Outpatient Acupuncture Effects on Patient Self-Reported Symptoms in Oncology Care. Here we look at the pre-post symptom change as a result of a single acupuncture outpatient treatment in our center. The areas in bold, so for example, where it says pain, mean change of minus 1.57, that suggests a clinically significant reduction in pain as a result of a single acupuncture treatment. You can see that for other symptoms, any change of 1 point or more is considered clinically significant. So you can observe there are multiple symptoms as a result of just one session that have that clinically significant reduction. Additional findings, now looking at data from pre-post oncology massage treatments, we can see here, I will take a step back here and share that in the past, we did offer in our center massage to both patients and caregivers. Due to the increased demand and volume of massage patients, we are no longer able to offer massage to caregivers in our center. And so now we're doing massage only for our patients. And so this data was actually gathered from when we did have patients and caregivers receiving massage in our center. And interestingly, what I marked in the blue boxes is that there were actually clinically significant improvements in symptoms of pain, fatigue, anxiety, sleep, and well-being for both patients and caregivers after a single oncology massage treatment. Also, for our group classes, in this case, we also offer, we'll take a step back. We offer yoga therapy led yoga classes, and using that same clinical model of pre-post assessment that we do in our clinical center before and after treatments like massage and acupuncture, we also do the pre-post assessment for patients and caregivers participating in our group classes, like our yoga class. Here we observe pain, depression, anxiety, and sleep as symptoms that are experiencing clinically significant reductions in terms of the experience of participants in these classes after a single session. We have a lot more work to do. I've been telling you that these assessments are pre-post of a single session, so more work needs to be done to look to the long-term effects of these interventions on the self-reported symptoms. And so what does all this information, what do all these clinical research efforts lead to? Well, the important thing is that they all contribute to advancing knowledge in integrative oncology. With advancing knowledge in integrative oncology, this leads to opportunities to actually develop clinical guidelines. Here I share an example of guidelines published just last year in a collaboration between the American Society for Clinical Oncology and the Society for Integrative Oncology, specifically for the integrative oncology care of symptoms of anxiety and depression in adult patients with cancer. Briefly, I'll share as an example, for patients with anxiety and depression, both during active treatment and post-treatment, you can see that according to the guidelines, there are benefits of mindfulness-based interventions as well as yoga. And so looking at these clinical guidelines can be a very helpful way of thinking about how the recommendations will be made to patients based on their needs and where they are in their cancer journey. And I'll share that there are more of these guidelines to come. And so putting together the efforts that have been going on in guideline development, our group, so you can see here, Dr. Lopez, Dr. Narayanan, and also Dr. Cohen, we put together a summary of the different guidelines that are out there that include integrative therapies. And here you can see, for example, with yoga, there is evidence in the guidelines, there are recommendations in the guidelines that yoga can be used to help with improving symptom control in areas of pain, arthralgias, fatigue, anxiety, depression, sleep dysfunction, nausea, cognitive dysfunction, and hot flashes, night sweats. And so as the evidence builds, the guidelines become more clear in terms of how it is that we can think clinically about decisions regarding not just what therapies to offer patients, but I like to look at these guidelines also as an opportunity to think more about if you are going to create an integrative medicine program, if you are going to develop an integrative medicine interdisciplinary team, what are the key components of that team that you would want to have so that then you can build a program that is able to provide patients these clinical-based guidelines. Pass off to you, Dr. Cohen. Thank you.
Yeah, perfect. Thank you, Dr. Lopez. That was a great overview of this area. And again, this chart, which will hopefully be invited to update as you all know, attending Nature Reviews Cancer is a very impactful review journal, and therefore they have a high impact factor because they publish reviews, but we're really trying to stick with the evidence. And I encourage you can download this article for free. And we do make comments in here that maybe not all of our colleagues in the field will be really happy with, because we call out some of the integrative modalities which we believe are not ready for clinical application. And there's a reason for that, because there isn't the A-level evidence. They may be safe, but if there's not a lot of evidence for efficacy, we'd prefer people to be engaging what you see on this slide, where there is the top level evidence lining up these symptoms for symptom control. I'm going to shift and talk a little bit first about lifestyle in general, and then go into some examples of actual research that we have done and have ongoing at MD Anderson. Dr. Lopez and I were just at the World Cancer Congress that was held in September in Geneva. And what you see on this slide was discussed at length and with, to some degree, utmost concern, in particular in low and middle income countries that are struggling with these issues now to the same degree that we in high income countries have been struggling with these issues, which is the modifiable cancer risk factors. It is estimated that at least 50% of cancer in our world could be prevented if we just modified our behaviors. In the case of pathogenic infections, if everyone, for example, were to be vaccinated against human papillomavirus, we would essentially not have cervical cancer on our planet anymore, and the majority of head and neck cancer, anal cancers would also slowly disappear. But even in high-income countries, at best, we're getting 50% vaccination rates against HPV, and then in low and middle-income countries, even worse. So continuing to be the number one modifiable risk factor is smoking and tobacco use. And the problem with everything that you see on this slide is these factors are relevant for somebody after a diagnosis of cancer. And as shocking as it may seem, we've met patients, interviewed patients who had lung cancer, and they were not advised by their doctor to stop smoking. Now, hopefully that's somewhat ancient history, but we know that modifying smoking, modifying weight, modifying alcohol consumption, even after a diagnosis of cancer that is lifestyle linked, will change clinical outcomes. Of course, exercise and diet are linked with excess weight, and it's not, just body mass index. It's actually that increased visceral adipose tissue that we're learning leads to inflammation in some hormonally related cancers like breast cancer, endometrial cancer. There is a very known biological connection there between excess weight and cancer outcomes. Alcohol, I'm just the messenger here, has clearly been called out as a carcinogen. And the World Health Organization, the American Institute for Cancer Research, AACR, essentially has positions now that there is no safe level of alcohol. Now, one drink a day, or ideally not even that much, is better than having two, and two is better than having three. So there's a dose-response relationship. In some cancers, this is really important after a diagnosis of cancer, such as breast cancer, bladder cancer, head and neck cancer. It's linked with 14 different cancers. Now, our biggest concern, and you're seeing that, I'm not the clinician in the group, and many of you are, is what are called these early onset cancers. And there was just a report published this past 2 weeks specifically about breast cancer. And again, in low and middle income countries, this is particularly troubling. And this is a number of different cancers. And you see one example of that here, which is colorectal cancer increase in early onset, meaning individuals who are under 50. And in many cases now, you're seeing women coming into your centers who are in their 20s and they're being diagnosed with breast cancer. Now, AACR hadn't said much about this until this most recent report. And here we go. Unhealthy diet, which is really the highly processed foods, are linked, of course, obesity, chemicals in the environment, most troubling. The use of antibiotics we know is linked with the microbiome, and I'll get to that in my last slide. Again, alcohol use, sedentary behaviors. again, I can't overemphasize all these factors are linked with outcomes even after a cancer diagnosis. And that's really where integrative medicine comes in. Dr. Lopez showed the guidelines for integrative modalities. These are the guidelines from the American Institute for Cancer Research, but the American Cancer Society, the NCI, the WHO, all these authoritative organizations have these recommendations for modification of lifestyle to be able to reduce risk of cancer. And again, the recommendation is after a diagnosis of cancer to follow these same guidelines. Yet, even with the most well-intentioned physicians, even those who are integrative medicine physicians have a hard time supporting patients in this area because there isn't a societal support for this, and many institutions don't even have the actual support of a dietitian or an exercise coach, etc. And modifying behaviors in adults, as you all know, being adults, and I'm guessing some of you have tried to modify your health risk factors, it's really hard, and support is often needed. What is often missing in the prescription, and this concept of the mix of six comes from a book that I've written that I'll just touch on very briefly. What's often not discussed about that brings us back to the more integrative model that Dr. Lopez shared is these three areas on the left. Sure, lots of talk about the concerns about physical activity, poor diet, environmental exposures, but rarely is a person's social network discussed, in the environment in which they live, and they're trying to make these difficult changes. Stress, we know, is a saboteur of all healthy intentions. Stress not only modulates the tumor microenvironment, making it more hospitable to cancer growth, but it also throws us all off track in all our healthy behaviors. And then sleep. Sleep is is something that is really often ignored and linked with our own metabolism. So we'll recommend somebody modify their diet, eat less, exercise more. If they're chronically sleep deprived, all the effects of that modification are going to be diminished. And we know that from very elegant studies that have done sleep deprivation studies, and you see how this change in metabolism. People who are sleep deprived tend to carry more weight on their body, is linked with obesity. What's important to know also is we're not just talking about quality of life. We know now from decades, if not at least a half century or more of research, that those 6 lifestyle factors are linked with key cancer hallmarks. And you're all familiar with the cancer hallmarks that, of course, keep getting expanded. The newest ones on here, it's not jumping out at me at the moment. Essentially the microbiome, why am I not seeing it in this list, is key factors for whether a mutated cell is going to grow and thrive in the body. So we know that chronic stress, that sleep have an impact on avoiding immune destruction. People who are more physically fit, eating a healthy diet, getting a good night's sleep, have higher cell-mediated immunity. We know that chronic stress actually has an impact on invasion and metastasis. And in animal models, as well as in human models, we know that individuals that and animals that are chronically stressed, there is an increase in what's called anoecus, the ability of that tumor cell to have broken off from the primary site and find that new home in the body, which we call metastasis. We know that diet, chronic stress, sleep deprivation, exercise have an impact on inflammation. So the key is not only just to improve a patient's quality of life, what these interventions do, but also to have an impact on the biological processes that we're all trying to target with conventional medical oncology, and ideally to perhaps harness the beneficial effects, for example, of immunotherapy by getting the patient in as physiologically healthy a state as possible, biologically having as strong an immune system as possible. So here's an example of the actual clinical application of two components of this integrative model. In this case, it's exercise and diet, and the objective of this clinical trial was to see whether patients who are engaging in exercise and dietary intervention would have greater adherence and less dose reductions in and around breast cancer chemotherapy. And in fact, that outcome ended up being negative because all the patients were very adherent to the chemotherapy, whether they were in the dietary intervention group, exercise, or the control group. But they did have a priori testing planned and a hypothesis to look at pathological complete response in patients who are getting neoadjuvant chemotherapy. So they received their chemotherapy for the 6 months leading up to surgery. And then at the time of surgery, they, of course, still remove the spot where there was tumor, and then through pathology examine whether there was any disease there. So pathological complete response, of course, means that there is no disease at the time of surgery. And they compared the two groups, diet and exercise versus the control. And here you can see that if they were in the control group, only 28% had a pathological complete response, whereas those in the intervention group, 53%, more than half, had a pathological complete response. So diet and exercise is just two components of what we consider a fully integrative approach to improving a patient's quality of life and health. And here we see a clear signal. We don't want to overinterpret a small clinical trial, but this was all hypothesized a priori. So in the book that I mentioned earlier that I wrote alongside my wife, who's a health coach, called Anti-Cancer Living, we lay out this concept of synergy. And this is really often missed within research because we research the different components of integrative medicine separate from each other. We've done so many studies of yoga, and I'll just show you one example of acupuncture, of massage, of a high fiber diet, this physical activity program versus that physical activity program. At best, what we see in the literature is a combination of two of these. So there's some studies that have done mindful eating studies. So, the combination of mindfulness with diet, or as you just saw the example of diet and exercise together, but rarely are they all approached together with a patient. And that's really what the goal of integrative medicine is. This book, by the way, is available in French and was written specifically to help guide patients in and around those 6 areas of lifestyle. I was a very close friend of David Servan Schreiber's before he died, and we actually designed a study together, and he wrote a wonderful book called Anti-Cancer, A New Way of Life. And this is kind of a sequel to that. How do we take that? And in this book, we're much more prescriptive, following the evidence, and importantly, from a medical perspective, luckily the editors allowed us to annotate the whole book that has over 1,000 references. So, and 70 pages of the book ended up being references, which is really important to have that science to share with the medical world, but also that the patients know that this isn't just conjecture and anecdote, because of course, anecdote is not data. And so that, of course, leads us into the model that you just heard about that we provide at MD Anderson for clinical care. Within research, we really look at all these domains. So we're looking at different mind-body practices, which include expressive writing, different forms of yoga, qigong, mindfulness. We've explored in the past massage and have published showing the benefits of massage, even in comparison to certain control groups. Multiple studies of acupuncture, actually just submitting now a multi-center acupuncture trial to look at symptom clusters. So we've typically looked at it, and I'll show you one example of acupuncture for a particular symptom, pain, xerostomia. But of course, our patients don't come to us typically with one symptom, right? They'll come with pain and fatigue and maybe issues with sleep. And so we're excited to kind of move into that area and starting to work internationally. One of our faculty, Dr. Pei-Ying Yang, is very interested in natural products and in special diets. And her laboratory is preclinical in nature, so doing this research with animal models of excess sugar feeding, for example. And we showed in breast cancer models that sugar consumed in the amounts that humans do really drives risk of breast cancer as well as progression of disease. And then her approach to natural products is looking at them like bioactive drugs that they are, and perhaps discovering new agents. So mistletoe, which you all know is used a lot just to the east and south of you in Germany, is not something that we use in the West, nor can we support, because it hasn't gone out of phase 2 clinical trials. Many suggestive phase 2 clinical trials. And so Dr. Yang's looking at that as just one example of the mechanisms of this and what are the components that are bioactive to potentially move this into further clinical trials. As I just described earlier, we're very interested in the comprehensive model with a number of studies approaching patients using the full mix of 6 lifestyle factors to see if that more comprehensive models would improve outcomes even more. Then the last area that I'm not going to get into and discuss in depth at all is this whole area of energy medicine that really needs to stay in the research context. A lot of what you see on this slide is already in clinical practice, so we're exploring it from different approaches. So just an example of some of the research that we've done on the harms of stress. So, why are we so concerned about stress in cancer patients? There's been, very elegant research in animals showing that stress modifies the tumor microenvironment, leading to progression of disease. But in this study was a large cohort of over 200 all stage 4 kidney cancer patients, so had a very similar prognosis, and then asking a number of different psychosocial questions, quality of life questions, controlling for all the usual biological factors. And we see here that at the time of diagnosis, those who are the most depressed do not live as long. We also see dysregulation of this one particular stress hormone. We also see high levels of norepinephrine, but in particular cortisol slopes. So a disruption in HPA axis functioning, which we know is a common stress response, is linked with depression and, again, worse outcomes. Importantly, we were able to look at gene expression pathways, comparing the most depressed to the least depressed. We also looked in the tumor microenvironment. This data was actually in looking at peripheral blood and seeing this for the most depressed, this upregulation of genes that are linked with inflammation, immune response, negative regulation of programmed cell death, aka apoptosis, increased activity in NF-kappa B pathways, STAT1. These are pathways that we're trying to target, right, with our chemotherapeutic agents. So clear biological evidence for the harms of stress. And of course, we know one way to improve a patient's mental health, as Dr. Lopez pointed out from the clinical guidelines, is something like yoga. There have been hundreds of clinical trials now on the benefits of yoga, and you see that it checked the most boxes on the symptom clusters. And this is one example. This was actually a 3-arm clinical trial, so trying to do it in a bit more of a blinded manner. So patients are told they're going to be in a behavioral intervention to improve their quality of life. One group does some simple stretching exercises, another group does yoga, and then we have a control group. And these were all breast cancer patients at the start of radiotherapy. And then you're seeing change scores here at the end of 6 weeks of radiotherapy, then 1 month, 3 months, and 6 months later. Not a huge difference by the end, but both, let's call them movement groups, had an improvement, but not statistically significant over the control group. But it's really over time that yoga group improves much faster and having much higher function than they did even before they started radiotherapy. And stretching is good, but it wasn't as good. It kind of falls in the middle. Where we really saw a favoring just of the yoga group was this measure of overall general health. Now, these are subjective measures and also benefit findings. So super important. If you're to ask me which measure I would want to see improve the most, it's this measure of finding meaning in the illness experience that remained above baseline levels just in the yoga group. These are all subjective in nature, but here you see cortisol slope. And as you saw earlier, in kidney cancer patients, the steeper the slope, the better the survival. That's also been published in breast cancer. Here we see at baseline, what the cortisol slope should look like, the diurnal rhythm, right? It's high in the morning, drops throughout the course of the day. By the end of radiotherapy, there was a blunting of the slope, but the yoga group maintained the steepest slope, significantly so, as well as 3 months later. So there's just clear evidence that chronic stress, and this is a wonderful article for those who want to go deeper, also published in Nature Reviews Cancer by another group, that chronic stress exacerbates tumor growth and spread. And there's so many things, as you saw, that we can do to help patients manage chronic stress. In the area of acupuncture, you saw some of the data. We've written a lot of systematic reviews. These get published in journals like JCO. And here's an example of just one study that we published just earlier this year that was acupuncture for chronic radiation-induced xerostomia head and neck cancer. Some of these patients had chronic xerostomia for 14 years, on average 4 years out. So importantly, we had a sham control group. And here you can see already the xerostomia symptom score, higher is worse, that there was a sham effect. And that's the case for essentially almost any symptom and any intervention for, in general, any symptom, whether it's cancer related or not, but a large, both statistically and clinically significant improvement between the true acupuncture versus waitlist. This was just bordering, but clearly not clinically significant either, but really no difference between the sham and the waitlist. And when we looked at quality of life, it was really all in favor of the true group. There were no differences between sham and waitlist. So xerostomia is currently not on the guidelines. This is our second phase 3 trial. So hopefully it will soon be on the guidelines. And then the last area of research I just want to touch on is this paper that we published a couple of years ago in Science. And I was one of the lead senior authors along with Trincari, Daniel, and Wargo. Jim Allison, Nobel Prize winner for immunotherapy, was a co-author on this paper as well. And we were interested in the impact that lifestyle, in particular in this study, diet, had on response to immunotherapy and survival of patients with melanoma. Everything was recapitulated in animals, and that's why it got published in Science in terms of the different dietary constituents, and then our interest in looking at probiotics. So here you see the patients who are consuming the what we call sufficient amount of fiber in their diet lived significantly longer, had a higher probability of survival during the follow-up period compared to those with insufficient fiber. We saw they also had a better immune response. So we looked at specific phyla and immunological outcomes as well. Again, all recapitulated in animal models showing more causal effect because, of course, these are associations. What was quite surprising to us was that the patients who were taking a probiotic were, in the earlier work by Wargo, showing that the diversity of the microbiome predicted outcome, aka the health of the microbiome predicted response to immunotherapy, led a lot of physicians to say, well, you should take a probiotic because that's going to help your microbiome. In fact, here we found the exact opposite, again, proven in the animal models as well, that the humans and the animals that were taking a probiotic actually had worse response to immunotherapy. And the only group here standing out on its own in the human models, which was the same in the animal, were the patients who were having sufficient fiber and not taking a probiotic. Why is that the case? We think that, lactobacillus or bifidobacteria, yes, these are healthy probiotics, but it's too much of one thing. And it actually leads to decrease in diversity because it's just too much lactobacillus crowding out the other healthy bacteria that we need in our diet. So we know really the safest way to increase microbiome biodiversity is eating a plant-centered diet, which is essentially the recommendation, increasing your soluble fiber intake. And the last year, I'm just going to touch on the super exciting research that we're doing with the use of psilocybin. In this case, it's for patients who are on maintenance therapy. So they have advanced disease, but they're not at the end of life. They have stable disease. They're on some type of treatment, have an unknown trajectory, and looking at the beneficial effects of psilocybin. And very importantly, not only just looking at patient-reported outcomes, but also biological measures, as well as looking at change in the brain and neuroplasticity to really be able to move some of these treatments that are being used on the side by patients without a lot of guidance, understand if they're beneficial, and then bring them forward into the clinic if they meet the appropriate criteria for being part of the standard of care. So those were just a few highlights of what's going on in the area of research, how we approach it. Those who want to learn more about integrative medicine, I encourage you to join the Society for Integrative Oncology that you see here. This will be our 21st meeting. So we've been around for a while now. It's going to be held south of Los Angeles at City of Hope, and then the next year a little bit closer to you in Boston, and encourage you to join us. So thank you, and I think we are now in Q&A session. We have a few more minutes to hear from you all.
Thank you so much for your presentation, and thank you for your work. It's truly inspiring and very essential for patients, not only targeting the disease, but taking care of the patient in all the dimensions of health. So now, and thank you for all the participants. So now we will invite you to ask a question you could have following this presentation. So I have one question here. So giving the evidence, why are there still barriers to clinicians signposting to resolve that not only help recovery, but also reduce recurrence risk?
You want to start there, being the clinician? I have maybe a more bias for you. Why don't you go ahead, Dr. Lopez?
Thank you. I was going to say, I'm not quite sure about the term signposting. So what?
Like they're not, like, it's not the standard of care, right? In most clinics, this isn't on everyone's prescription pad, and even worse, it's not actually reimbursed in the United States by insurance companies. I know in Europe, acupuncture variably is used in different countries. Why isn't it the standard of care around the globe? Is essentially a summary of that statement.
I think that there's definitely been a large movement towards making it the part of the standard of care, but it definitely still is not part of the standard of care, the integrative oncology. And I think it's just a matter of, as evidence continues to build and the scientific community begins to see that these therapies do, have, true benefits in terms of patient care. I think that just needs to continue in that path. So just continuing to have providers that are looking to the evidence and making recommendations. Establishing trust is important. If integrative medicine teams are outside of clinical centers, it's important that whoever's outside in the community is working actively with those in cancer centers and having communication and collaboration. Too often there's been this idea that integrative medicine is outside of conventional medicine, and that if someone does integrative medicine, they're going to be lost in the community, perhaps to this provider that's not going to be linking back to the primary health provider. And so I think the evidence is important, but then also that trust that, that there's going to be a collaboration taking place in terms of how patients are accessing integrative therapies. I'll pass to you, Dr.
And I think this is changing, though. So the relationship between the SIO, as you saw, has been around for 21, 22 years. And it's only in the past 6 years that we have a formal partnership with ASCO to develop guidelines. So, NCCN has always had a focus on integrative medicine. But I think the ASCO guidelines are perhaps used and looked to more at an international level. Because NCCN is really made up of US-based cancer centers. And I think, the next generation coming out, it's going to be part of oncology education, the importance of this integrative approach, no longer something that is learned as postgraduates. It'll be part of the curriculum. And the SIO is actually working now on writing a formal medical textbook on integrative oncology. And so then there'll be this educational resource. And I think that's how all of this happens. It takes time. It takes time even to change conventional medical practice, let alone here things that weren't even taught in med school, as an example. In terms of finances, I can jump in, and then Dr. Lopez.
Yes.
So somebody asked about how we fund this. So again, it's variable across states, and we make this comment in our Nature Reviews cancer paper that it shouldn't be variable across, at least in the United States, across states. And if, for example, acupuncture, there is evidence and it's on the guidelines for pain, it should be reimbursed by the medical system, whatever you would call that. In Belgium, it's the third-party payers often. It should be just covered as the standard of care. Blue Cross Blue Shield of Texas doesn't reimburse for acupuncture, but in California and in New York, they do. United Healthcare and Aetna and other healthcare insurance companies of Texas do reimburse for acupuncture. So it's very inconsistent. And some things are just not reimbursed, like yoga is not reimbursed yet. And we try and offer our group programs where it's free for patients. And either the institution pays and it's what we call the loss leader, or, for example, for the acupuncture, if insurance doesn't pay, then the patients would have a fee for paying for the acupuncture that would be comparable, or we try and price ourselves a bit below what it would cost them to get acupuncture in the community.
The next question: how long after the end of the treatment do you propose these types of care?
I can definitely speak to that and say that, that integrative medicine recommendations are at any point in treatment. And so it can be from the point of diagnosis, during active treatment, into survivorship. We work with patients also with advanced cancer or end-of-life situations as well. And so, it just depends on, where they are in their cancer, treatment journey that, can affect what the recommendations are. Right? And so depending, if is a patient having symptoms from their cancer therapy, perhaps trying acupuncture for the chemotherapy-induced nausea, vomiting. Is a patient looking to lose weight in terms of helping to reduce the risk of recurrence after they finish, for example, their breast cancer treatment? Well, then, working with patients on nutrition, exercise, health psychology, helping with that lifestyle component of integrative medicine. So it just really depends on the patient's diagnosis and where they are on their cancer journey, what their needs are. We just adjust. There isn't one formula for everyone, right? It really has to be personalized to the patient's individual needs, where they are.
We are coming to an end of the webinar. So a big thank you for your participation. All the participants, Dr. Cohen and Dr. Lopez, and thank you for your presentations and your availability and your inspiring work. We hope this session provide you a better understanding of integrative oncology and the benefits for the patient. Stay tuned. We will have a new webinar, educational webinar in November. So see you soon, and thank you for your participation. Goodbye.